Why are certain cohorts of patients, particularly the elderly and alcoholics, at such elevated risk for developing hyponatremia and the risks associated with its rapid correction? This tutorial looks at urinary osmolality and why it's so important in this setting. I guarantee you'll learn something. Hyponatremia. Further thoughts about hyponatremia and urinary osmolality. This time I will discuss understanding urinary osmolality, why elderly patients are at risk, why alcoholics are at risk, and why you need to feed your patient. First, some introductory comments. It's my impression that a lot of doctors tie themselves in knots trying to meticulously manage hyponatremia, and not infrequently one sees a roller coaster picture of sodium going up and down with dextrose on, dextrose off, DDAVP on, DDAVP off. Although there is, with reason, a major fear of osmotic demyelination syndrome, we do see rapid shifts in plasma osmolality in a variety of clinical situations. For example, universally in neurosurgery and neurocritical care, we see it with acute kidney injury, particularly when patients start on intermittent hemodialysis, trauma, rhabdomyolysis during diabetic emergencies like diabetic ketoacidosis or HONC. And none of these patients, in my view, seem to encounter osmotic demyelination syndrome. I've never seen a certain case of it. It's vanishingly rare, but it does occur. And the cases I've seen of osmotic demyelination, roughly half of those patients had rapid correction of sodium either up or down, and half we could not explain. So I often wonder, is there something special about the patients who develop osmotic demyelination? Also, it's very important to understand that the obsession with sodium is a little bit misguided, because sodium represents only 50% of osmoles in serum. There are other osmoles: chloride, urea, glucose, bicarbonate, lots of them. And there are also a whole bunch of byproducts of protein metabolism represented by urea that are essential components of aquaresis. And if urinary solute is low, then sodium, potassium, and chloride are sacrificed. And so one thing I will point out at the beginning, and I'll explain this in a couple of minutes and I'll explore it, is that if you're having trouble correcting hyponatremia, heads up, feed your patient. I want to move on to talk about a massive emerging problem worldwide, the epidemic of frailty that we are now seeing because people are living so much longer with poor health. Frailty is defined as progressive loss of physiologic reserve associated with aging. 5 components were described by Fried in 2002: unintentional weight loss, fatigue or exhaustion, diminished muscle strength, low levels of physical activity, and slowness. And the term that covers a lot of what happens because of all of this is sarcopenia, loss of lean body mass. Frail elderly patients are terrified of falls, and that hugely reduces the amount of exercise that they take. Frail elderly patients are typically malnourished with a body mass index of lower than 20. They may subsist on what we call tea and toast diets. A high proportion of their dietary intake is derived from carbohydrates and convenience foods. In many ways, they are victims of food deserts. The food industrial complex has moved away from providing consumers with small portions, for example from a butcher or a baker or a fishmonger, to large multi-packed products that makes shopping and cooking for one extremely difficult and extremely expensive, with a lot of waste. And often elderly patients have low incomes. Moreover, the diet industry has spent 60 years maligning meat, fat, and salt, and promoting low protein, high sugar, ultra processed foods. The result is inadequate protein, fat, and salt and micronutrient intake, reduced energy levels, slowness, sarcopenia, and the risk of falls. Physiologically, elderly patients have age-related reduction in urinary concentrating capacity. We all know this. This is a reduction in GFR. So they find it harder to clear stuff. But frequently the other side of the coin is missed. They also have age-related reduction in urinary diluting capacity. And that means that they have problems clearing water from their diets. And I'll explain this in a few minutes. They're also likely to be on natriuretic drugs, thiazides, furosemide, ACE inhibitors, angiotensin receptor blockers, etc., all of which tend to waste sodium in the urine. The combination of malnutrition, salt avoidance, loss of renal reserve, high water intake and drugs makes these patients particularly vulnerable to develop hypotonic hyponatremia with water overload. The other group of patients who are particularly at risk for developing this are alcoholics. We teach our medical students that there are two types of alcoholics, those who are well fed and those who are malnourished. The malnourished alcoholics come in two forms: the emaciated ones who really look like they haven't eaten anything for a long time, and then the bloated ones who may have pot bellies, may be very edematous looking, but they also have protein energy malnutrition. One subgroup of alcoholics subsist almost entirely on beer. They may drink up to 24 cans of beer a day, and what's really problematic about this is that the beer contains quite a lot of calories in the form of both alcohol and carbohydrates, but contains no protein, no fat, and minimal salt. As a consequence of this, despite being able to match their calorie requirements from beer, they have very high water and very low salt and protein intake, and this causes huge problems. Aquaresis is the capacity of the kidney to excrete electrolyte-free water. That is essentially the ability to dilute the urine. And you cannot release water from the body without solute. There is a maximum urinary dilution that can be achieved. And for the majority of patients, that magic number is 50 milliosmoles per liter. That's as low as most patients can go. Some can't even get down that low. When we look at what makes up these urinary osmoles, it's really important. We excrete about 900 milliosmoles of solute per day. 300 of those are derived from urea. 10 grams of urea is 50 milliosmoles. 300 come from sodium and chloride, and 300 come from potassium, magnesium, bicarbonate, calcium, phosphorus, sulfate, ammonia, uric acids, and other metabolic junk products such as creatinine, amino acids, etc. The lowest achievable urinary osmolality, as I've mentioned, is 50 milliosmoles per liter. That means, though, to excrete 1 liter of water, that's aquaresis, one must have 15 milliosmoles available. To calculate the maximum volume of urine excretion per day, you divide the daily solute excretion by the lowest urinary osmolality. That's the maximum dilution, 50 milliosmoles per liter. So, for example, what is the maximum urinary volume if the daily osmol excretion is 900 milliosmoles? And what is the maximum excretion if the daily osmol excretion is 300 milliosmoles? So let's look at Bill. Bill is excreting 900 milliosmoles per day. He has a normal kidney, and so that means that the maximum dilution achievable for him is 50 milliosmoles per liter. So if we divide 900 by 50, then we get 18 liters per day. Pretty spectacular amount of urine, but it's just the potential. Remember, most people don't drink that much water that they're going to excrete that amount of fluid. Alcoholics do, though. If Bill's urinary osmoles were 300 milliosmoles per day, that's 300 divided by 50, and that makes up 6 liters per day. If Bill cannot concentrate his urine below 100 milliosmoles, then it's 900 milliosmoles divided by 100, or 9 liters per day. For 300 milliosmoles, that is just 3 liters per day, which is really, really, really bad. A 70 kilogram alcoholic who doesn't consume any protein will auto-cannibalize 35 grams of protein from their body per day. And this produces about 170 milliosmoles from urea, in addition to other metabolic junk products of about 75 milliosmoles, with a total of 245 milliosmoles. That's not a lot, right? Remember Bill? If they consume 24 cans of beer, that's 24 times 330 mils, and those cans will only provide 75 milliosmoles of solute in the 8 liters of water that they are consuming. So the total urinary solute is 245 plus 75. As a consequence, assuming that this alcoholic is even able to maximally dilute his urinary output maximally is 320 divided by 50, or 6.4 liters. Taking into account insensible losses, the water gain is 500 mils to a liter per day. And that is not great. That means the patient will become water overloaded and hyponatremic. And take into account that if there is any increase in ADH secretion for any reason, vomiting, diarrhea, patient has a trauma, or they're in surgery, then they may not be able to dilute their urine below, for example, 100 milliosmoles per day. And this markedly reduces urinary output. Well, what happens when solutes are reintroduced? 1 liter of saline contains 308 milliosmoles per liter. If the patient can achieve the maximum dilution of 50 milliosmoles per liter, then it's 308 divided by 50, or 6 liters. So for every 1 liter of saline given to a patient, 6 liters of diuresis results. And if Bill is 70 kilos and has a body water of 40 liters and is water overloaded by 5 liters with a starting sodium of 110, what will his sodium rise to after 1 liter of saline? Well, let's work the problem. We have Bill, 70 kilograms, sodium of 110, given 1 liter of saline. Can you calculate the impact of giving 308 milliosmoles per liter? Well, I've already shown you this. 308 divided by 50 is 5 liters of urinary output, and that is Bill's total water overload. If Bill's baseline body water is 40 liters and he's water overloaded by 5 liters, then his total body water is 45 liters. Can you calculate out the impact on sodium? This is the calculation you do. It's the plasma sodium multiplied by the total body water divided by the baseline body water. And that number is 123. So when he has his diuresis, his sodium will rise by 13 millimoles per liter. And that is pretty impressive. And that's why you need to be really careful with patients who are chronically malnourished, who are chronically hyponatremic, because they are at huge risk of not just refeeding syndrome, but hyperacute rises in sodium, and that will put them at risk of osmotic demyelination syndrome. And the picture is the same for all patients with marasmus like malnutrition, starvation, elderly patients, drug addicts, etc. Ultimately, beer, potomania, and other forms of alcoholism results in water overload, hyponatremia, and autocannibalism from visceral and skeletal protein utilized for substrate. There is marasmus-like malnutrition or cachexia, but there may be a beer belly because of fat derived from carbohydrates. Also, keep in mind that although doctors obsess about the careful management of hyponatremia when patients are admitted, hypernatremia, that means a sodium of more than 145 millimoles per liter, follows in a staggering number of these consequence of intravenous saline fluid and drugs. They also are often aggressively diuresed. Diuretics tend to get rid of water more than salt, so the sodium goes up. In many ways, it seems to me that this predisposes a certain cohort of our chronically critically ill patients to osmotic demyelination syndrome. And we have picked this up in patients who never had a dysnatremia, who never had a rapid rise in sodium, but had the risk factors of malnutrition and chronic alcohol abuse. Just some final thoughts. You will encounter patients in whom it is virtually impossible to correct hyponatremia by fluid restricting them or giving them sodium or other electrolytes. Feeding the patient may resolve the problem. However, you need to be careful. Reintroduction of oral or enteral nutrition in these very high-risk patients increases the risk for aggressive aquaresis and dangerous sodium correction rates, and also refeeding syndrome. Now let's look at the high-impact points. To clear water from the body, there must be sufficient osmotically active material in the urine. Normally, 900 milliosmoles is excreted per day. Urea is the most important of these. Malnourished patients have high water and low protein intake. They cannot clear water until they are given solute. Be careful with hypernatremia in later critical illness. So that was all about urinary osmolality in the setting of hyponatremia. If you found this useful, follow my tutorial series at ccmtutorials.org or at ccmtutorials on YouTube, and don't forget to subscribe.